Welcome to my YouTube channel. Today we are going to talk about evaluation of ulcerative colitis. As we dig in, make sure you subscribe. Let's begin. So, in terms of diagnosis of ulcerative colitis, if you are new here or you are a returning subscriber, you all know that before we begin our evaluation, you have always to take a good history and physical examination. If you are writing in your exam papers, that is the first point that you have to begin. So it must give you a clinical picture, that is a patient who comes in with diarrhea for more than 3 months that has blood in it, that is hematochezia, and also patient who comes in with fecal urgency, mucus plug, feces, mucus and feces, as we have talked about in the old slide of ulcerative colitis, in addition to laboratory and endoscopy findings. So pathology is obviously required for the diagnosis of ulcerative colitis. That's why when you do endoscopy, you have to take a biopsy. So as I've said before, a colonoscopy and mucosal biopsy are gold standard investigation for diagnosis of ulcerative colitis. So, and also just another repetition, the diagnosis of ulcerative colitis is based on the presence of diarrhea for more than 4 weeks and evidence of chronic colitis on endoscopy and biopsy. So the blood test, we're going to start with our full blood count, and in terms of that, hemoglobin, we can also detect anemia, which is an indicator in this, as you're going to see, leukocytosis and thrombocytosis, and these factors are indicative of severe disease in terms of ulcerative colitis. The next thing in lab, you're also going to check the metabolic panel, that is you can see low albumin, low potassium, and also low hypomagnesemia. This is because this patient comes in with chronic diarrhea. Obviously, they have lost the electrolyte and fluid imbalance. The next, you're also going to see elevated alkaline phosphatase. This is most, and also alkaline phosphatase and GTT. These are supportive of primary sclerosis cholangitis. So the next thing we're going to talk about is the inflammatory markers, which are CRP and ESR, which are markers of severity, in addition to fetal calprotectin, which also indicates mucosal inflammation. Next thing we're going to do is stool assay. This stool assay is very important in terms of ruling out the differential diagnosis, that is infective gastroenteritis. So you take a stool culture and also for Clostridium difficile infection for cysts and parasites in addition to that. The next thing is serological markers. These are antibody assays, which is P-ANCA, which is elevated in ulcerative colitis, and ACAR, which is elevated in Crohn's disease. So they can both be elevated in inflammatory diseases, but when P-ANCA is present, it's indicative of ulcerative colitis. The next thing is radiological studies. This just gives us a picture of, they don't give us a clear picture whether we have ulcerative colitis. They just give us a suggestive picture. In addition to that, they show us signs of complication. So in an X-ray, you can see loss of colonic ulcer, which is lead pipe appearance. You're going to see in the next slide, and this one is most commonly in severe cases. In addition to that, signs of complications such as toxic megacolon. This is massive distension, which include mucosal islands and loss of aspiration. So the distension is greater than 6 millimeters, and also loss of aspiration and increased bowel thickness. This is because of the edema, the edema and mural hyperenhancement. So a chest X-ray will also be done in terms of ruling out perforation if perforation has occurred, which is a complication of ulcerative colitis, and risk of perforation is more common in acute disease. So in terms of chest X-ray, you'll find loss of haustra, increased bowel wall thickness, mural hyperenhancement, and also signs of complications such as you have said, toxic megacolon. So you can see this is the lead pipe appearance. So in terms of endoscopy is key, and when we said when you do endoscopy, you take a biopsy, and after taking the biopsy, you do pathology. So in terms of endoscopy, ileocolonoscopy is used for diagnosis and also for disease monitoring. In terms of severe disease where you have acute severe ulcerative colitis, it is contraindicated. And the reason why it is contraindicated, it increases the risk of perforation, and therefore what we do instead, we do sigmoidoscopy, which is kind of a lower endoscopy. So you can also do EGD to rule out Crohn's disease. So what are the findings when you do endoscopy? In terms of early disease, you're going to see pre-recurval ulcers, inflamed edematous mucosa, loss of superficial vascular pattern. You're going to see imaging that will follow. Chronic disease, you're going to see loss of ulcer, loss of mucosal folds, strictures, deep ulcers, and also rare position in terms of advanced disease, you're going to see pseudo polyps. So as I've said, there's a video I've made on classification of ulcerative colitis. You can go and watch it, and in it you're going to see the Mayo classification, that is the endoscopic classification in terms of severity, and then it's grouped in 0, 1, 2, 3, where we have normal disease, mild, moderate, and severe disease. If you see in this normal, where you have normal vasculature, and then in mild disease you have erythema, you have decreased vascular pattern, in addition to mild friability. In moderate disease, you're going to see marked erythema, as you can see all over in the place, absent vascular marking. If you take this image and differentiate with this image, you can actually see the difference, and also friability and erosion. In severe disease, where you see spontaneous bleeding as indicated here, and ulceration. Another score to measure the severity of ulcerative colitis in terms of endoscopy is ulcerative colitis endoscopy index of severity, which is 1 to 8. So in terms of that, we just have three components: the vascular pattern, bleeding, erosions, and ulcers. So in each you go and grading. So in the first one, where you have vascular pattern, this is the vascular pattern is patchy or obliterated, as you have viewed in the previous image, which of the normal, you can see this one is patchy or obliterated. In terms of 2, it is actually completely obliterated. You cannot actually see a vascular pattern around here. And in 3, it's a combination of 1 and erosions and ulcers, which is you have superficial ulcers, and you also have patchy obliteration of the vascular patterns. Here it's a combination of 2 and 2, as I mentioned before, and then here it's 2, 2, and 1. In terms of 1, in terms of bleeding, is where you can see some mucosal bleeding, just spotty mucosal bleeding. And then you combine vascular pattern, which has 2 points, bleeding pattern, which has 2 points. This means you can see actually some blood in the mucosa plus erosions 2 points. In terms of 7, where you have vascular patterns, which is cut 2 and bleeding, now you can see actually frank bleeding in the mucosa and erosions and ulcers. In terms of 8, where you have now vascular patterns 2, bleeding, where you already said bleeding is 8, and then erosions. Now these are deep erosions and ulcers. So we have already talked about now the endoscopy. Now we said when you do endoscopy, you take a biopsy, and in the biopsy you're going to obviously take it into the pathology. In terms of pathology, you're going to see in terms of histology. If it's early disease, you're obviously to see granulocyte infiltration, that is the neutrophils, and this is limited into mucosa and submucosal. Kindly note that this disease, that ulcerative colitis, is limited into the mucosa, unlike Crohn's disease, which is transmural. In addition to such, that you're going to see crypt abscesses, and in chronic disease, in terms of, if you know chronic inflammation and acute inflammation, you're going to see lymphocyte infiltration right now, and then mucosal atrophy, altered crypt architecture, and then epithelial dysplasia. So this is just an image to show you in terms of healthy state and ulcerative colitis, where you have neutrophils, as you already said, goblet cells depletion, crypt distortion, crypt abscesses, and fat cell metaplasia. So this is just a question. A 28-year-old man undergoes pseudomoscopy, which is kind of a lower endoscopy, for long-term standing diarrhea and weight loss. On visualization of the rectum, the mucosa appears to be flamed and friable. Rectal biopsy is taken, and histology shows mucosal ulcers with inflammatory infiltrates, crypt abscess with goblet cell depletion. From the list of the answers below, which is the most likely diagnosis? So we have already talked about this. So which is the most likely diagnosis and why? Should I leave you to answer the question or not? So our answer is ulcerative colitis. Why? If this patient came in with diarrhea, and obviously this diarrhea, we don't know, but it might be blood stained. And then the patient was done an endoscopy, and it showed the mucosa, that's a keyword, to be inflamed and friable. And then a biopsy was taken, and then the biopsy, what did we see? Infiltrate, crypt abscesses, and goblet cells. Goblet cell depletion, what we have just talked in the previous slide. So I hope you have understood. Thank you.